Hello, good afternoon, everybody. Welcome to this session, which is a free paper session regarding spinal cord injury and trauma. We got three presentations. My co-host here for this session is Mr. Almas Khan, who will join us in a few minutes. So can we have the first presentation, please?
Hi there.
Hi there.
My name is
Colin McCulloch.
I am an
I am an
FY1
FY1
currently working at the Queen
Queen
Elizabeth
Elizabeth University Hospital in Glasgow.
This is
our presentation on the study we
performed within the Institute of Neurological Sciences on the management and outcomes of dish fractures in the west of Scotland, a 17 years experience. Diffuse idiopathic skeletal hyperostosis, or DISH, was first described by Forrester in 1950 and was previously known as Forrester's disease. It is characterized by flowing ossification of the anterior aspects of at least 4 vertebral bodies. It is a frequent incidental finding in the elderly and is most commonly asymptomatic. DISH patients are predisposed to fractures from low energy injury as a result of a long lever arm effect conferred by the ankylosed spine. There has been a push in recent years for surgical fixation of these fractures due to faster bony fusion through superior stabilization of the affected segments. As there have been few studies or publications on this topic, the aims of our study were to describe the characteristics of and clinical outcomes for these DISH fractures. We interrogated our regional imaging database for CT reports involving DISH fractures. Fusion was defined as bony bridging between the involved segments on CT or plain radiograph, and sequential images were used to identify when bony fusion had occurred. Patient records were obtained through our clinical portal database to identify if patients were either managed conservatively or surgically. Requests were submitted to the Spinal Injuries Unit to access FIM and SCIM scores for our cohort of patients. From our interrogation of the available data, a total of 35 fractures associated with DISH were found in 32 patients. 15 of these fractures affected junctional zones between C6 to T12 and T11 to L2, with most of these occurring within the vertebral body. Most were flexion-type fractures. As expected, many were low-energy injuries. Most of our patients went on to receive conservative management in either an orthosis or a halo brace. 4 patients required surgical management in the form of fixation fusion. 81% of our patients achieved bony fusion within 180 days. This bar chart illustrates the Asia grading of our patients at admission versus discharge. 18 had no neurological deficits, and of those who did have deficits, most remained static by discharge, while 3 improved from grade D to grade E. None deteriorated. FIM scores for our 9 patients admitted to the Spinal Injuries Unit were compared to a control group comprised of non-DISH fractures. Our DISH patients exhibited an average change of 12 points from 58 to 70 throughout their stay. SCIM scores, however, were only available for 3 of our patients, and the average SCIM score improved from 29 on admission to 58 at discharge, and were on average lower than controls. In both FIM and SCIM measures, our DISH patients had similar motor and SCIM trend lines to controls. So the prevalence of DISH fractures will increase in the future due to an aging population, but a high index of suspicion will be required due to the associated low energy trauma and reduction in function these are associated with. Fortunately, these fractures can be treated conservatively with good clinical outcomes. So these are the references used for our background and introduction, and I would just like to thank you for your time.
I am Dr. Aju Bosco from the Orthopedic Spine Surgery Division of Madras Medical College, India, and I will be presenting on the feasibility, safety, and outcomes of treatment of neglected post-traumatic AO type F4 injuries of the subaxial cervical spine using the anterior-posterior-anterior approach. Subaxial cervical facet dislocations are AO type F4 injuries, which are distractive flexion injuries. Surgical management of these injuries presenting at or beyond 3 weeks since injury is technically challenging. Few studies are available in literature, but they are conflicting and controversial. Different surgical strategies have been described with varying rates of success in achieving reduction, but none are effective in all scenarios. Then there is no consensus yet on a single management protocol. We analyzed the difficulties encountered during delayed surgical management of these injuries with or without neurological deficit, to propose an effective surgical strategy for the same and to analyze its feasibility, safety, and outcomes. In our study, we included patients with subaxial cervical facet dislocations presenting at or beyond 3 weeks since injury. We did a single center retrospective cohort study on 24 patients with subaxial cervical facet subluxations or dislocations presenting at or beyond 3 weeks since trauma. Under a single anesthesia in stage 1, through an anterior Smith-Robinson approach, we released the cicatrized anterior longitudinal ligament and performed a discectomy. In the second stage, with the patient turned to prone position, through a posterior midline approach, we performed a facetal arthrolysis or a facetectomy to aid in reduction of the dislocation. This was followed by posterior stabilization and fusion. In the third stage, through the previous Smith-Robinson approach, we performed an anterior reconstruction with tricortical iliac crest autograft or cage along with anterior cervical plating. Clinical, functional, and radiological outcomes were analyzed based on the following parameters. A total of 24 patients were treated, and the mean follow-up was 27.5 months. Road traffic accidents and fall from height were the most common modes of injury. Mean delay at presentation was 7 weeks, and the maximum delay being 24 weeks. C6, C7 was the most common level involved. The VAS scores and neck disability index scores showed significant improvement at final follow-up. 20 patients had complete pain relief at final follow-up. All patients showed significant neurological improvement, and there was no neurological worsening in any patient. The success rate of reduction was 91%. One patient with osteoporosis had graft subsidence with implant loosening, and this patient eventually had an acceptable cervical spine alignment with good functional outcomes. There was one case of superficial wound infection which settled with intravenous antibiotics. This patient presented 12 weeks after a fall from height. On evaluation, he had a C5, C6 facet dislocation with bilateral perched facets. He was managed using this approach, and at 42 months follow-up, he had a significant improvement in neurology with a stable, fused, well-aligned spine. The success rate of close reduction performed 7 days after injury is only 20%, whereas in subaxial cervical facet dislocations presenting 6 weeks after injury, the success rate reduces to 16%. Reactive fibrous tissue formation around the facets and uncovertebral joints, disruption of adjacent soft tissues, remodeling of articular surfaces, and cicatrization of anterior longitudinal ligament and disc preclude a successful close reduction. Circumferential release is the key to achieve a successful reduction. In literature, authors have described different approaches to treat neglected cervical facet dislocation, but literature lacks a clarity and a consensus. In comparison with previous studies, ours is the largest series thus far. In stage 1, we released the anterior longitudinal ligament and removed the intervertebral disc, which prevents reduction through cicatrization. Discectomy performed before attempting reduction prevents neural injury. In the second stage, a facetal arthrolysis or a facetectomy may be needed in very old dislocations to aid reduction. A near normal reduction is attained without much force. In the third stage, remaining disc material is extracted out from the disc space after reduction, and an appropriate size bone graft was inserted and stabilized with cervical locking plate. This technique aids in safe reduction of neglected facet dislocation. It has a 91.7% success rate. It restores normal spinal alignment, needs least manipulation, and hence is safe to the cord and achieves good clinical and radiological outcomes. Thank you.
Good evening. I'm Smriti Sriram, a second-year medical student at St. George's University of London. The title of my research is Review of Classification in Traumatic Pediatric Thoracolumbar Fractures. Classification systems are essential because they help assess the extent of injury, guide with treatment plan, improve communication between healthcare professionals, and is useful in research. It requires to be comprehensive, have a logical structure, simple and easy to use, includes the stability, morphology, neurology, and mechanisms of injury. Classification systems are not used or researched extensively in the pediatric population yet. So the two questions that intrigue me are, could anatomical differences at various stages of growth affect treatment choice? And is TLIX and AO spine transferable to the pediatric population? The two classification systems that I decided to assess were TLIX in 2005 and AO spine classification of thoracolumbar injury in 2013. The thoracolumbar injury classification system by Vaccaro in 2005 looks into the morphology of injury, integrity of posterior ligamentous complex (PLC), and neurological status. It requires the use of MRI to evaluate PLC integrity. AO spine in 2013 by Vaccaro looks into the morphology of fractures, neurological injury, and patient-specific clinical modifiers. MRI is not required by AO spine to evaluate PLC complex, and hence use a CT scan. The following are my aims. First will be to explore the validity and reliability of AO spine and TLIX in the pediatric population, and to assess the transferability of AO spine and TLIX used in adults to pediatrics. The methods are the systematic review PRISMA guidelines were followed to make this paper, and the search timeline was from November 2020 to December 2020. The following databases were searched: Medline, PubMed, and Oxford Academic. The results include 6 articles, out of which 3 was on TLIX, 2 on AO spine, and 1 on both. The number of observers in total were 63, and they were neurosurgeons or orthopedic surgeons. Number of patients in total were 466. 4 out of 6 studies looked at validity. The validity of TLIX was almost perfect, and the validity of AO spine and TLIX combined both had a strong association rank. 3 out of 6 studies looked into the inter-rater reliability. The inter-rater reliability of PLC was moderate in 2 studies, as seen by Savage et al. In 2015, 0.524 and 0.60, which decreased the overall inter-rater reliability of TLIX. Finally, the study that looked into AO spine had a substantial overall inter-rater reliability. 2 out of 6 studies looked at intra-rater reliability. There was an almost perfect intra-rater reliability for AO spine, and the overall intra-rater reliability for TLIX was substantial. There are few papers that explore the use of adult classification system in pediatrics, and there is no specific classification for pediatric thoracolumbar fractures. 6 papers were found that use adult classification system in pediatrics. MRI has a poor reliability in detecting PLC. Hence, we agree AO spine supersedes TLIX. This highlights MRI is not an essential part in decision-making for spinal trauma. MRI is not required if there are no neurological deficits. The last point is it's important to take into consideration that growing children have obvious implications with the insertion of spine instrumentation. This has to be taken into consideration during treatment. In conclusion, there was a good overall validity and reliability for the application of TLIX and AO spine in pediatric spine trauma. The validity was almost perfect for TLIX. TLIX and AO spine have a strong association rank. Inter-rater reliability was moderate for TLIX and substantial for AO spine. Inter-rater reliability was substantial for TLIX and almost perfect for AO spine. Therefore, ladies and gentlemen, AO spine can be used in absence of any other classification system for pediatrics. Thank you.
Okay, thank you for all the speakers. Almas, do you want to start questions?
Thank Thank you very much. We've got a question here, which I think the has already answered on behalf of Dr. McCullough. Dr. McCullough. So I don't want to add anything to that, Dr. Pang. Just benefit of were the indications for operative non-operative management in DISH, and Dr. Pang said that they generally prefer a non-operative approach. Failure of non-operative management, difficulty nursing, and worsening neurology are the main indicators for surgery. The average time of surgery admission in the 4 patients was 12 days. Dr. Pang, I've got a question to add on to that. Did you identify reasons for any of the non-unions that occurred? And for those that didn't unite, what was the outcome? I don't know whether you're able to answer that. And Helen, if possible, the 2 speakers into the presenter section as well.
They're all in there. It just looks like she's obviously having problems with her microphone.
The question, Dr. Pang, was for the patients who didn't unite their fracture, what was the outcome for those? And were there any factors you identified that led to that non-union?
I heard the second part, any factors that might have attributed to the non-union. I think it generally depends on whether the patient can comply with the non-operative plan of bracing and bed rest, and also nutrition. And what we found also is whether the patient, when I say nutrition, in terms of whether the patient is cachexic or overly obese. Cachexic is worse than obesity in terms of unions of fracture. What was the first part of your question? Sorry.
What was their outcome? Did they do well after they didn't unite, and then you treated them? Did they go on to do well after that?
Yes, they did eventually achieve union, but it took a longer time. I do not have the specific time difference on my hand, but they did eventually unionize. Eventually.
Okay, Ahid, have you got any other questions? I've got a question for Aju there. I was very interested about these delayed fractures that you treated so successfully. Did you encounter any technical difficulties in your arthrolysis or facetectomies or taking down the cicatrized area?
Actually, am I audible? Yeah, actually in facet dislocations which presented more than 2 months since the time of injury, it was not easy to perform a facetal arthrolysis. And even after doing an arthrolysis, what happened was the facets were nearly fused, so we had to remove the superior part or burr out the superior part of the inferior facet, and we achieved a reduction. So that is a useful tip if we are using a burr to burr out the superior part of the inferior facet, and or at times we may have to remove the inferior part of the superior facet as well, so that we can achieve reduction without the use of much force.
Okay, thank you very much. Ahid, have you got anything?
Yeah, just question to the last speaker regarding the classification. You mentioned in your talk that the MRI scan is not important to classify or to find about the spinal cord injury. But how are you going to find out if there's ligamentous injury only without a fracture?
Sorry, could you repeat the last question?
Yeah, just you mentioned that MRI scan is not an essential modality for classification, or in pediatrics especially. My question is, how are you going to find out if there is only ligamentous injury without any fracture?
I'm really sorry. We're going to have to cut this short because we've overran. But please continue to chit-chat in the networking lounge. But we do need to move on to the next session.
Okay. Okay. Thank you, everybody, for attending this session. Thank you.
Thank you.